Thank you, Mr. Chairman. Congratulations on your win last night. And I want to thank all the witnesses. You've given superb testimony. And what I'm so is that in all of the basics of life, whether it's clean water, electricity, connectivity relative to broadband, healthcare. There really is a national shame that surrounds what is taking place, and I think really true neglect for Native Americans. So there has to be the political will to get these things done. These are not issues that we don't know how to address. It's a matter of political will. So thank you for your testimony. And there's, to me, an enormous sadness that surrounds all of this. Let me start by asking Dr. Grimm and Jonathan Nez and Christine Sage, have your tribes been able to get adequate PPE, diagnostic testing supplies, and other resources like ventilators and drugs to treat COVID-19 cases in your communities? One of the challenges is getting adequate supplies. And it seems to me that there's confusion regarding how Indian health programs can access the strategic national stockpile. So have tribes been able to access the strategic national stockpile? Any one of you can address that?
Yeah, thank you. This is Jonathan Ness. Thank you, Representative Eshoo. In terms of your question, the Navajo Nation, did get some supplies from the Strategic National Stockpile, but it took some time before that resource came to the nation. And when that also came to the nation, we also noticed that some of the items and those supplies were outdated. But we did have to use what we were given because of the shortage throughout the country. Of course, that first spike, there was just so many governments and out there and municipalities wanting to get PPEs, and so tribes were left bidding on this finite resource out there. And sometimes tribes, most of the time, maybe all of the time, tribes were on the back burner. And states like New York and other states were getting the most of these supplies. But we are hopeful that the other industries out there will be supplying more PPEs. And maybe it's time for tribes to develop their own stockpile for their nations as well. Thank you, Representative.
That's a good idea. To Ms. Sharp, what clarification do you think is necessary to allow tribes to be able to access the stockpile?
I think there needs to be clarity in direct access. It was very clear to us early in the pandemic that those outside of the United States, the World Health Organization, the IMF, the World Bank, all understand the vulnerability to indigenous populations. And there's been a call out for global action to address the desperate needs among indigenous communities because everybody recognizes our vulnerability. And so to the extent there's an economic recovery plan, a global strategy for building economies, I think there's an appetite to work to safeguard our economies. We also saw that the World Health Organization called for private sector partnerships with the UN Foundation and the Swiss Philanthropy Fund. So to the extent this pandemic exceeds the scale of public resources, we know there's a global strategy to prop up national economies. We know there's a global strategy for public-private sector partnerships. So that's what we need. We need resources.
I appreciate your answer. Just very quickly, in the California area of the Indian Health Service, the last IHS hospital closed its doors over 5 decades ago. So my constituents and tribes in my area rely on the California Tribal Health Program, which receives very limited annual funding from IHS. So to Dr. Grimm, how are areas like mine with no IHS hospitals and a reliance on tribal health programs treated differently in funding allocations? How best to address?
One of the things I was going to say, Congresswoman, was that IHS as a whole doesn't have that much in the way of intensive care units. There are a number of areas across the IHS that have 0 hospitals, and those that do have it have relatively small number of ICU beds. Our hospital has 6 beds, 6 ICU beds. They happen to all be full today, and so we are at capacity on ICU. Early on, we tried to get resources such as testing materials, testing machines, other things like that, and a lot of times and ventilators too. Somebody would say yes, and they would turn around and pull it back because it needed to go to a higher priority. And so what those places have to do that don't have those resources, they have to rely on the purchased and referred care dollars. They are absolutely at the mercy of that to send somebody off to a hospital that has that sort of capacity.
Thank you, Mr. Chairman, and I yield back.